automatic exposure control, KVP and MA selection, and compensating issues. This is chapter 13 from the Faber and Johnston book, Essentials of Radiographic Physics and Imaging. As a radiographer, it is our job to select exposure factor techniques to produce quality radiographic images for all different kinds of equipment and patients. There are many combinations of KVP, MA, SID, exposure time, image receptors, and grid ratios. When combined with patients of various sizes with different pathological conditions and body habitus, the selection of the proper exposure factors kind of becomes tricky. An AEC system is a tool available on most radiographic units, and it's there to assist us as radiographers. The AEC system, it's also called automatic exposure device or automatic exposure control, and you can also hear it referred to as phototiming. But it is used to control the amount of radiation reaching the image receptor by terminating the length of exposure after the radiation has passed through the patient. So instead of without an AEC, after the radiation has already gone through the patient, when we do not have an AEC, the radiation will continue to go until our exposure time is up. But with an AEC, once the AEC detects that the radiation has gone through the patient, it terminates that exposure. So this will allow for radiation protection measures because it's limiting the amount of exposure that your patient will receive. Technique charts make it easier for us too. They have technical factors on there, and it allows it to be more manageable to be able to pick out the technique that we need for each exam and the different sizes of our patients. But there's always patient factors that require your assessment and your judgment. So even though we have these technique charts, and even though the machines are calibrated for each exam and they already have the technique set in the control panel, we still have the availability to increase and decrease our KVP, our MA, our exposure time, and anything necessary that we need to adjust dependent on the patient's size, the patient age, pathology, all kinds of different reasons. So even though we have an AEC system and we have the techniques already calibrated into the equipment that we're using, we can change the KVP, the MA, we can change anything that we want. So we have to make sure that we know the patient size, the patient shape, the patient habitus. We ask the patient history. And, you know, if the patient has a certain pathology, we know to either increase or decrease our technique. The AEC device determines the exposure time, so we don't have to really worry about the exposure time because the AEC does that for us. The AEC system is excellent at producing the consistent levels of exposure when used properly. The radiographer should also be aware of the technical limitations using an AEC system. Detectors are the AEC devices that measure the amount of radiation transmitted. The radiographer selects the combination of detectors that they want to use. There are two types of detectors in the AEC system: the phototimer, which is a first generation of AEC systems, and then the ionization chamber, which is more common used today. All AEC devices work by the same principle, that radiation is transmitted through the patient and converted into an electrical signal, terminating the exposure time. This occurs when a predetermined amount of radiation has been detected, as indicated by the level of the electrical signal that has been produced. Service personnel can calibrate the predetermined level of radiation to meet the departmental standards of image quality, but also the radiation standards of the National Center for Radiation Protection. That's what I meant. The difference in AEC systems lies in the type of the device used to convert the radiation into electricity. Phototiming specifically refers to the use of an AEC device that uses photomultiplier tubes or photodiodes. These systems are not common today. Today we use the ionization chambers. Those are the most common type of AEC system. Regardless of the type of AE system used, all systems use a set of 3 radiation measures, detectors arranged in some specific manner. The radiographer selects the configuration of these devices, determining which of the 3 individually or in combination measure radiation exposure reaching the image receptor. These devices are called the sensors, the chamber cells, or detectors. The radiation measuring devices are referred to as detectors. So if you are using the detector for, let's say, a chest x-ray, you will pick the top 2. So there are 3. And on the next slide, you'll see those. But there are 3 on every bucky. And you'll pick the top 2, which is left and right, for a chest x-ray. If you're doing an abdomen, you'll just pick the center one. So here's the upright bucky unit that I was talking about. And you can see the arrangement of the 3 automatic exposure controlled detectors. And you can see the top 2 are for a chest x-ray. Just think of the right lung and the left lung. And then you would pick the center for an abdomen because we're just getting the abdomen, which is in the center of the body. So that's how I remember it. Most AEC systems use these 3 set of radiation measuring detectors. And the radiographer will be the one that selects the configuration of these devices. Now, on most modern x-ray equipment, the detectors are already calibrated into the control panel. So once we select chest x-ray on the control panel, the top 2 AEC will already be activated. When we pick abdomen, then the middle detector will be activated. So it's all calibrated in there, but you can most definitely change it if you need to. The phototimers use a fluorescent or light-producing screen and a device that converted the light to electricity. A photomultiplier tube, or we call it a PM, is an electronic device that converts visible light energy into electrical energy. A photodiode is a solid-state device that performs the same function. Phototimer AEC devices were considered exit-type devices because the detectors are positioned behind the image receptor. So that radiation must exit the image receptor before it is measured by the detectors. These are the exit-type devices, light paddles coated with a fluorescent material served as the detectors, and then the radiation interacted with the paddles, producing visible light. The light was then transmitted to remote PM tubes, which is the photomultiplier tube, or photodiodes that converted this light into electricity. The timer is tripped and the radiographic exposure was terminated when a sufficiently large charge had been received. This electrical charge was in proportion to the radiation to which the light paddles have been exposed to. The phototimers have largely been replaced with ionization chamber systems. So the phototimers had these paddles and were used back in the day. But that's ancient history now. Now we use the ionization chambers. So this picture here shows the phototimer automatic exposure control system. The detectors are located directly below the image receptor. This is an exit type device in that the X-rays must exit the image receptor before they are measured by the detectors. And you can see the light paddles underneath the image receptor. Together with the photomultiplier tubes, they measure the radiation exposure after it passes through the cassette. Ionization or ion chamber is a hollow cell that contains air and is connected to the timer circuit via an electrical wire. Ionization chamber AEC devices are considered entrance type devices, opposite of the phototimers, which were exit devices. Because the detectors are positioned in front of the image receptor so that the radiation interacts with the detectors just before interacting with the image receptor. So there's a difference between the phototimers and the ionization chamber system. So the phototimer, it did not turn off the radiation until after it already hit the image receptor. With the ionization chamber system, after the radiation exits the patient, it hits the ionization chamber and the exposure is terminated before hitting the image receptor. When the ionization chamber is exposed to the radiation from a radiographic exposure, the air inside the chamber becomes ionized, and that creates the electrical charge. That charge travels along the wire to the timer circuit, and then the timer is tripped, and then the radiographic exposure is terminated at that time when there's a large enough charge that has been received. The electrical charge is in proportion to the radiation to which the ionization chamber has been exposed. Compared with the phototimers, the ion chambers are less sophisticated and less accurate, but they are less prone to failure. Most of today's AEC systems use the ionization chambers and not the phototimers. The AEC serves the same role as the exposure timer in the primary circuit. The AEC is programmed to terminate exposure when a predetermined level of electric charge is received from the detector. The ionization chamber reacts with exit radiation before it reaches the image receptor. Air in the chamber is ionized, and then the electrical charge that is proportional to the amount of radiation is created, travels to the timer circuit, and then that is where the exposure is terminated. Shown here in this figure, this is the ionization chamber automatic exposure control. The ionization chamber automatic exposure control system has the detectors located directly in front of the image receptor. This is an entrance type device because the X-ray exposure is measured just before entering the image receptor. When a radiographic study is performed using the AEC, the total amount of radiation, which is your mass, is required to produce the appropriate exposure to the image receptor, and this is determined by the AEC system. Many radiographic units include a mass readout display, and you can see the actual amount of mass used for the image, and it's displayed immediately after the exposure, but sometimes only for a few seconds. It is critical for the radiographer to take note of this information. Knowledge of the mass readout has a number of advantages. It allows us to become more familiar with manual exposure technique factors. If the image is unacceptable, knowing that mass readout provides a basis from which we can make exposure adjustments by switching to a manual technique. There may be procedures with different positions in which AEC and manual techniques are combined. because of difficulty with accurate centering. Knowing the mass readout for, let's say, an AP lumbar spine will give the radiographer an option to switch to a manual technique for the oblique exposures, making technique adjustments based on reliable mass information that we had on the mass readout. AEC controls only the quantity of radiation reaching the image receptor and therefore has no effect on other image characteristics such as contrast. The KVP for a particular examination should be selected without regard to whether an AEC device is used or not. The radiographer must select the KVP level that provides an appropriate subject contrast and is at least the minimum KVP to penetrate the part. Contrast can be computer manipulated in digital imaging. The KVP should still be selected to best visualize the area of interest. A high KVP is used for chest imaging with a grid to best visualize the widely varying tissues. In addition, the higher the KVP, the shorter the exposure time needed by the AEC device. Because high KVP radiation is more penetrating, reducing the total amount of X-ray exposure to the patient because more X-ray photons exit the patient. And the detectors are measuring the quantity of the radiation. The preset amount of radiation exposure is reached sooner with a high KVP. So using a higher KVP with AEC is going to decrease the exposure time and overall mass needed to produce a diagnostic image, which will significantly reduce your patient's exposure from radiation. The term minimum response time refers to the shortest exposure time that the system can produce. Minimum response time is 1 millisecond with modern AEC systems. Usually is longer with AEC systems than with other types of radiographic timers. Other types of radiographic timers are usually able to produce shorter exposure times than the AEC devices. Sometimes this can be a problem with some segments of the patient population, such as pediatric patients and uncooperative patients. We want to increase the MA so the time of exposure terminates more quickly. If the minimum response time is longer than the amount of time needed to terminate the preset exposure, then an increased amount of radiation is going to reach the image receptor. With pediatric patients and others who cannot or will not cooperate with the radiographer by holding still or holding their breath during the exposure, AEC devices may not be the technology of choice for that, because we want to set our exposure time very short so that it does not allow the pediatric patient or patients that are not cooperating, it won't allow them to move if we have a short exposure time. Backup time is the maximum length of time the X-ray exposure continues when you're using an AEC system. The backup time may be set by us or may be controlled automatically by the radiographic unit. It may be set as a backup exposure time or as backup mass, which is the product of MA and exposure time multiplied together. The role of the backup time is to act as a safety mechanism when an AEC system fails or the equipment is not being used properly. So in either case, the backup time protects the patients from receiving the unnecessary exposure to radiation and protects the X-ray tube from reaching or exceeding its heat loading capacity, the maximum heat units. If the backup time is controlled automatically, it should terminate at a maximum of 600 mass when equipment is operated at or above 50 kVp. So the function of the backup time is the maximum exposure time allowed during an AEC exam serves as a safety mechanism when the AEC is not used properly or is malfunctioning. Backup time should be set at 150% to 200% of the expected exposure time. This allows the properly used AEC system to appropriately terminate the exposure, but protects the patient and tube from excessive exposure if a problem occurs. AEC devices are equipped with a mechanism called an exposure adjustment, and this is also known as density controls. It allows the radiographer to adjust the amount of preset radiation detection values, also known as the density controls. And these are in the form of buttons on the control panel that are numbered -2, -1, +1, +2, and then sometimes you'll see +3. The actual numbers presented on the exposure adjustment vary, but each of these buttons changes exposure time by some predetermined amount or increment expressed as a percentage. A common increment is 25%, meaning that the predetermined exposure level needed to terminate the timer can either be increased or decreased, either plus 25% or minus 25%, or 2 increments, 50% or minus 50%. Selection of the detector or detectors to be used for a specific exam is critical when you're using the AEC system. AEC systems with multiple detectors typically allow us to select any combination of 1, 2, or 3 detectors. Radiographic equipment can also be purchased with 5 AEC detectors, which provides greater flexibility in imaging a wide variety of patients. The selected detectors actively measure radiation during the exposure, and the electrical signals are averaged. Typically, the detector that receives the greatest amount of exposure has a greater effect on the total exposure. Measuring radiation that passes through the anatomic area of interest is important. The general guideline is to select the detectors that will be superimposed by the anatomic structures of greater interest that need to be visualized on the radiographic image. Failure to use the proper detectors could result in either underexposure or overexposure to the image receptor. In the case of a PA chest radiograph, the area of radiographic interest includes the lungs and the heart. Therefore, 1 or 2 outside detectors should be selected to place the detectors directly beneath the critical anatomic area. If the center detector is mistakenly selected, the anatomy superimposing this detector includes the T-spine. If the exposure is made, the resultant image will demonstrate sufficient exposure in the spine with the lungs overexposed. Although brightness was adjusted by the computer, the actual mass applied and exposure indicator reflect the image overexposure. So it is important for us to evaluate image quality, the applied mass, and the exposure indicator when using the AEC device. Many radiographic units have AEC devices in both the table bucky and the upright bucky. So if more than 1 bucky per radiographic unit uses the AEC, it's very important that we are certain to select the correct bucky before making an exposure. Failure to do so may result in the patient and image receptor being exposed to excessive radiation. The backup timer is reached, the exposure is terminated, and then a repeat radiographic study must be done, increasing the patient's dose. A similar problem can occur when not using a bucky, such as with a cross table, tabletop, or a stretcher or wheelchair studies. So if the AEC system is activated with these types of exams, an unusually long exposure is going to result because the detectors are not being exposed to radiation. So again, the backup time will probably be reached, the patient's dose will be excessive, and the radiographic units are designed so that an exposure does not occur if the AEC device has been selected, and so there is no image receptor detected in the bucky. Accurate centering of the area of interest over the detectors is critical to ensure proper exposure to the image receptor. If the area of interest is not properly centered to the image receptor, we could have over or underexposure that may occur. Shown in this figure here, this is centering. And in figure A, the center detector was selected for this T-spine and the central ray midpoint to the T-spine. In figure B, the central ray was centered over the right lung field. The resulting radiograph demonstrates appropriate brightness levels in the right lung and ribs, but the thoracic vertebral bodies are underexposed. So we have to make sure that we are using proper centering. The size of the detectors are fixed and cannot be adjusted. The patient's anatomic area of interest needs to be adequately covering the detector combination. If the detector combination is larger than the area of interest, then we must turn off the AEC and use a manual exposure technique instead. It is therefore critical that the radiographer determine whether the anatomic area of interest can adequately superimpose the dimensions of the detector combination. And this will lie true with pediatric patients. Patient factors affect the time the exposure takes to reach the image receptor and ultimately affects the image quality. So variations in patient thickness result in changes in the time of exposure accordingly if the AEC system is functioning properly. Pathologic conditions, contrast media, foreign objects, pockets of gas are patient variations that may affect the proper exposure to the IR and then ultimately the image quality. Excessive or insufficient collimation may also affect the amount of exposure reaching the IR. Insufficient collimation may result in excessive scatter reaching the detectors, which will result in the exposure time terminating too quickly. So that will make your image light. And then excessive collimation may result in exposure time that is too long, making your image dark. So we want to make sure that our beam restriction is on point. The AEC system is calibrated to the type of IR that we're using. So if an IR of a different type is used, the detectors will not sense the difference and the exposure time will terminate at the preset value and the image quality may be jeopardized.